Elbow stiffness. Published by WordPress.com. Elbow stiffness. Anatomy and normal range of motion, ROM. Normal ROM. Flexion, 145 degrees. Extension, 0 degrees. Supination, 90 degrees. Pronation, 90 degrees. Functional ROM. Loss of flexion causes more disability than loss of extension. Pathophysiology and etiology. 1. Congenital causes. Cerebral palsy, CP. Arthrogryposis. Radioulnar or humeroradioulnar synostosis. Congenital radial head dislocation. 2. Traumatic causes. Fractures, dislocations. Post-surgical stiffness. Brain injuries. 3. Infectious causes. Tuberculosis. Pyogenic arthritis. 4. Inflammatory causes. Osteoarthritis, OA. Rheumatoid arthritis, RA. Gout. 5. Neoplastic causes. Pigmented villonodular synovitis, PVNS. 6. Other causes. Burns. Myositis ossificans. Loose bodies. Complex regional pain syndrome, CRPS. Classification. A. Intrinsic stiffness. Joint incongruity. Intra-articular fractures. Capsular contraction. Synovitis. Osteochondritis dissecans, OCD. Inflammatory arthropathy, e.g., RA, gout. Osteophytes, coronoid or olecranon tip. B. Extrinsic stiffness. Ischar following burns. Loose bodies. Heterotopic ossification. Ligament contractures. C. Mixed stiffness, most common. Combination of intrinsic and extrinsic factors. Clinical presentation. Symptoms. Limited ROM. Pain, if associated with inflammation or injury. Disability affecting daily activities. Clinical evaluation. 1. History taking. Onset and duration. Probable cause, e.g., trauma, burns. Previous treatments, e.g., splinting, physiotherapy, surgery. Work and life demands. Associated symptoms, e.g., pain, swelling. 2. Examination. Evaluate overall upper extremity function. Inspect skin and soft tissues, e.g., ischar, scars. Assess ROM and compare with the contralateral side. Neurological examination, especially ulnar nerve function. Imaging. X-ray, AP, lateral, oblique views. Fractures. Osteophytes. Joint incongruity. CT. Better for identifying fractures, loose bodies, and osteophytes. MRI. Not routinely necessary but can assess ligament and tendon pathology. Prevention. Early active ROM exercises. Avoid prolonged immobilization. Treatment. A. Conservative management. First line for contractures less than 40 degrees. Physiotherapy with active and passive ROM exercises. Serial splinting. NSAIDs. B. Operative management, if conservative treatment fails. 1. Soft tissue procedures. Capsular release, with or without release of posterior band of MCL. Excision of heterotopic ossification, once mature. Removal of loose bodies. 2. Bony procedures. Osteophyte excision. Corrective osteotomy for mal-united fractures. Resection of radioulnar synostosis. And 3. Specialized procedures. Musculocutaneous neurectomy for neurogenic contractures. Outerbridge procedure. Olecranon fossa fenestration. Distraction interposition arthroplasty, for young patients. Total elbow arthroplasty, for elderly, low-demand patients. Complications. Persistent stiffness. Neurological injury, e.g., ulnar nerve. Recurrent heterotopic ossification. Joint instability following extensive release.